welcome to the 200 ELSA meeting. On this, because of the COVID-19, we have to use the technology to help us to join together for a conference. Today, I'm William Chen from Taiwan, and today I'm hosting this section that's the colon surgery section. And we have various speakers that is very famous from Asia. And we have Jungi Kim, we have Simon Ng, we have Mena Shane, and Professor Naito. And Uehara from Japan. She's not on yet. So yeah, because of time factor, we have to start out our meeting now. And the first speaker will be Jungi Kim. I think Jungi has no need to be further introduced. He's a very famous colorectal surgeon from Korea, and he has demonstrated his surgery all over Asia, and have written many manuscripts and publications. And he's actually the godfather of the laparoscopic colectomy here in Asia. So we'll have him to talk on CVL and CME. And please, Jungi, share your slide, please.
Okay. Everybody can see?
Yeah. No, share, Jungi.
What?
Share your slide and you can start your talk.
Share.
Yeah.
Okay. Now?
Okay, start your talk.
Now, okay?
Yeah, and
okay. Now, okay?
Yeah, good.
Thank you very much. Because, William?
Yes.
I put my sound in
Okay.
my PPT because my language barrier.
Yeah, it's okay. Jungi, we cannot hear your song.
Yeah. Can you hear my sound? Thank you.
No more song.
Really?
No.
No sound?
Is the result?
No sound?
No.
No sound?
No.
Okay, so I will try again.
Of MRC classic trial. 10
No sound?
recurrence rate of right colon cancer is
Okay.
almost triple compared to the rate of left-sided and
William, no sound?
No, yes.
This
Okay, thank you.
is obvious evidence telling us that there is a significant problem in the right colon
What
cancer.
happened?
In 1908, Dr. Moynihan, the surgeon of Leeds General Infirmary, mentioned in his article that the surgery of malignant disease is not the surgery of
Oh,
organs,
why? What happened?
anatomy of the lymphatic.
It's very noisy. Why?
Japanese standard
It's
dissection
different.
has
Oh
been
my God.
used at the cancer.
William, it's very strange.
Yeah,
Talk and different.
it's okay. It's okay. Just let the sun go.
Oh my God.
Jingy, just play the song.
Institute
The song
Hospital
is okay.
since 1946. And Dr. Toyota introduced this
Oh, yeah.
procedure in his article published in 1995.
Now, okay.
I assumed that they used CVL technique, even though they did not use the term CVL.
Okay.
Dr. Thronetz and Grimson said that 5-year survival rate is better in high ligation than intermediate ligation in his article published in 1997. I think one of the theses in their paper is that they emphasize the importance of central radicality, although the paper used the term high ligation at the time, but I think they were obviously talking about the importance of CVL. In the paper published in DCR in 2003, Dr. Bokeh said the colon cancer specific survival rate improved more than 10% after adopting the technique for precise dissection along the anatomic planes. This paper emphasized the importance of plane dissection, or CME. After Dr. Moynihan's publication regarding colon cancer surgery in SGO, the concept of a wide excision was adopted by leading group surgeons. However, this concept was not yet used universally by all surgeons. After 100 years passed, and in 2008, a new paper was published from the same lead general infirmary. Dr. West from Lead General Infirmary assessed the quality of colon cancer surgery. They used colonic rating system to their specimens. I prepared another picture for your better understanding. Picture A shows damages in both colon and mesocolon, while picture B in mesocolon only. Picture C is the mesocolic plane dissection. It is a very good plane for surgery. And you can see that there are no damages in both colon and mesocolon. This article shows how important it is to perform the mesocolic dissection in colon cancer surgery. Surprisingly, only 32% were found to meet the condition of proper mesocolic plane dissection. Before talking about mesocolic plane dissection, we need to know about Tolt's fascia. This is Dr. Carl Tolt, the anatomist we all should remember. This is the expanded view of Tolt's fascia, which was described in Dr. Culligan's paper. Two images below describe mesocolic plane dissection. The image on left-hand side shows mesofacial separation, and the image on right-hand side shows retrofacial separation. Which do you think is better? I think it does not matter as long as the mesocolic fascia is not damaged. I am showing you the picture of a plane dissection described by my Japanese friend in order to emphasize the plane dissection we talked about in the previous slide. It shows again the mesocolon with its enveloped vessels. Black and green arrows are the correct embryological plane for dissection, which is the mesocolic plane. If the mesocolon becomes damaged, it will be an intramesocolic plane, whereas If the damage extends to the colon wall, it will be a muscularis propria plane, which results in a poor quality specimen. Let's go back to the Dr. West's paper. We can see the impact of mesocolic plane dissection. The survival rate in mesocolic plane dissection is 15% higher compared to muscularis propria plane dissection in all stages. And there's a remarkable 27% increase in stage 3. This picture tells us the reason why the plane of mesocolic dissection is so important. With tumor envelopes inside the vessels close to the mesocolic surface, if this mesocolon is damaged during the operation, the tumor cells can spread into the peritoneal cavity. This is the picture of a mesocolic plane dissection with high ligation, described in a well-known article published in 2009 by Dr. Hohenberg of University of Erlangen, Germany. Hohenberger team reported that since 1978 to 2002, 5-year local recurrence rate had continuously decreased by using CME and CVL. In respect to survival rate, it had continuously improved. In his article, Dr. Hohenberg said optimal surgery is a meticulous mobilization along the embryologic plane and ligating arteries at their origin. Dr. West is such a thoughtful pathologist. In order to suggest the optimal colon cancer surgery, he compared the Erlangen CME with a severe specimen with a Japan's T3 dissection specimen in a paper published in 2012. Difference in longitudinal radicality was noted between the two groups, but no significant difference was found in central radicality. Moreover, both groups showed high mesocolic plane dissection rate. Let's go back to our previous slide again. Now, we are going to try to review Dr. Turnbull's article, no-touch isolation technique, published in 1967. In 1967, Dr. Turnbull introduced medial to lateral dissection, and he named it no-touch isolation technique. Dr. Turnbull and his colleagues said no-touch isolation technique resulted in better 5-year survival rate than conventional technique. But some criticized this 5-year survival rate data is resulted by extended resection, not by no-touch isolation technique, even though there are controversies about the superiority of no-touch isolation technique. I believe Dr. Turnbull's theory is ideal to the colon cancer surgery. In the era of open surgery, surgeons preferred lateral to medial approach. However, from the introduction of laparoscopic surgery, medial to lateral approach started to become popular. I cannot figure out exact reason for the change, but I believe that it was easier to perform under laparoscopy. Anyway, this is another benefit of laparoscopic surgery. These are the benefits of the laparoscopic surgery proved by lots of studies. Dr. Jamali measured the degree of difficulty of laparoscopic colorectal surgery in accordance with tumor location through survey. As a result, splenic fracture resection and the transverse colectomy have the highest degree of difficulty. Dr. Sjo of Oslo reported this paper in the Colorectal Disease, 2008. As you can see, he stated that tumor location is a prognostic factor in colonic cancer patients. The survival rate of the transverse colon, splenic fracture, and the descending colon were found to be worse than that of cancer from other sites. Ray et al. Reported that tumor subsite location is a prognostic factor for survival after colon cancer diagnosis. In their analysis, sigmoid colon cancer prognosis was better than proximal colon or transverse colon cancer. Dr. Bangu also noted that post-operative survival varied according to the anatomical segment in which the cancer has occurred. Sigmoid colon cancer showed better post-operative survival compared to transverse colon cancer and splenic flexure colon cancer. In our discussion today, we talked about the lymphatic system of Moynihan from UK, no-touch isolation technique of Rupert Turnbull from USA, D3 dissection of Japan, and the CME and CVL of Hohenberg from Germany. I think the concept of Hohenberg came out from the integration of those ideas.
We have to finish up your
great principles in all of my open and laparoscopic surgery during my journey.
No, you need not.
The study date is from April 1995 to December 2010, and I divided them into 3 groups. Group A indicates right hemicolectomy and extend the right hemicolectomy. Group B is the transverse colectomy, left hemicolectomy, and extend the left hemicolectomy. Finally, Group C is the sigmoid colectomy and anterior resection. Is the difficulty of CME with the CVL same for each group? Of course, they are different. Therefore, you may expect long-term outcomes among my 3 groups will be different.
Can I finish?
Previous papers data showed.
After this, just this.
They are truly different. As we look at the Kaplan-Meier curves, there was no significant differences at 5 years disease-free survival rate or overall survival rate among the 3 groups. But Group B yielded the highest average operating time, while Group C was the shortest, because CME with the CVL for transverse colon and the splenic flexure colon cancer are difficult.
I can't control here.
Okay. Well, it's 10 minutes over the time that you were giving, so
I'm sorry.
It's okay. And we leave the discussion later. So we'll have our second speaker is from Japan. Professor Naito, and Professor Naito is the chair and professor of Department of Lower Gastrointestinal Surgery in Kitasato University, Japan. And Professor Naito is a graduate from the Tohoku University Medical School. And he was trained in the United States and also have some time working with Michel Gagné. And he's an expert in the fields of colorectal surgery as well as bariatric surgery in Japan. So he will be discussing on the laparoscopic right colectomy with D3 dissection with a coaxial port setting. May I have Professor Naito now?
Thank you. Thank you very much for giving me this opportunity. Well, let me share the slide. Hold on. Okay, today I'm going to talk about the fundamentals of the laparoscopic surgery, which makes surgery comfortable to perform. So endoscopic surgery reduces tactile sensation, basically performed with the 2D images, and the magnified and narrow view often leads to disorientation of anatomy. Besides the limitation of the instrument movement is the biggest difficulty in performing precise surgery. Well, the coaxial setting theory is the basic concept of trocker's placement to make it easy to perform precise operation. Briefly, well, place the display monitor on the line connecting the surgeon and the target organs, and insert the telescope on the same axis. That's why we call it coaxial. and insert the surgeon's instrument from both sides of the telescope. So we apply this concept to the right colectomy, and this would help to perform precise operation. Especially in the right colectomy with D3 lymph node dissection needs to dissect around the fragile vein, requiring precise operation. Therefore, the coaxial port setting will help to perform easy operation. So I'm gonna show you the trocar placement with this concept. A manipulation area is shown as a gray area, and this is the port site. We use the 5 trocars, and the telescope will be inserted from the left lower quadrant, and on that line, we're gonna set the display monitor. And umbilical and the left upper quadrant port will be used for dissection, and the 2 other ports on the right side will be used for retraction. Then I will show you the video. Let me do some other. Okay, can you see that?
Yeah.
The first assistant surgeon grabs the iliac vessels and following up anteriorly, and dissection is started under the iliac vessels. Usually, the first we seek the superior mesenteric vein, about 1 or 2 centimeters below the root of the iliac vein. Yeah, now we're doing that. Using the Maryland dissector, we're gonna expose the superior mesenteric vein like this, and dissect the fat tissue around the vein with the ultrasonic coagulating shears. Yeah. And then we're gonna dissect the lymph node around the superior mesenteric vein upward. And then dissect all of the fat tissue around the vein. This kind of a precise dissection requires very precise manipulation and also the dissection. For that reason, that the coaxial setting, which is very close situation with the conventional surgery, gonna help to perform the very precise dissection of the surgery. And also, the left instrument of the surgeon is coming very close to the target organ, which is coming from the umbilicus area. So the distance between the trocars and the target organ is very close. It leads to stability, very stable manipulation can be done with that left hand. Now we dissect from medial to laterally, just about the duodenum and the pancreas. And go upward again. And we expose the root of the middle colic artery. And then the accessory vein. We seek the accessory vein of the right column. In this case, we're gonna dissect the accessory vein from the cranial side of the transverse mid column. And so we taking down the transverse column caudally and dissect the hepatic flexure of the transverse column. here. You can see that?
Yeah.
And that black point is that the tattooing before the surgery and where the tumor located. Yeah, this is the accessory vein of the right colon. We dissect it from the cornea side sometime. Well, we do mostly from the caudal side, but in this case, it was hard to do from the caudal side, so we switched to dissect from the cranial side. It doesn't matter which way. Then flip up the transverse colon again. And we dissect the right branch of the middle colic artery. Yeah, right here. And then dissect it after the clipping. Then we flip up the older small bowel and the right side colon upward, and then take down the attachment of the lateral side of the right side colon. Then we create the small incision at the umbilicus and retrieve the specimen out there, and then making the hold on. Making the anastomosis with the hand-sound technique. So in conclusion, the coaxial setting theory is the basic concept, makes procedures easier and simple. And also coaxial port setting will help precise dissection around the vulnerable vein, which is mandatory for D3 lymph node dissection for the right side colon cancer. Thank you very much for your attention. Thank you.
Thank you very much for your excellent talk. And we'll leave all the questions at the end of the section. And we'll proceed to our next speaker, Simon Ng from Hong Kong. Professor Ng is a very good friend of mine and is a very famous colorectal surgeon around Asia. And he's currently is a professor of surgery in Chinese University, Hong Kong, and he's also a very good robotic surgeon. So today he's gonna give us a talk on the hybrid endolaparoscopic colorectal surgery. I think this is probably the trend of the future. And Simon, please.
Thank you very much, William, for your introduction and also invitation. And also thanks to David for the invitation. So I'm going to share my screen first. Okay. All right, so now I'm going to talk about hybrid endolap colorectal surgery, and I have to finish the talk in 10 minutes. So I'll try my best. So I do not have any disclosure relevant to this talk. Now, endoscopy and laparoscopy are two essential components in the treatment of colorectal disease, but each modality has its own limitations. Now, for endoscopy, it is only applicable endoluminally, only amenable to superficial lesions, small lesions, and there is limited hemostasis and suturing ability. Whereas for laparoscopy, for endoluminal lesion, it has quite imprecise localization. Instruments are rigid, so it's reduced degree of freedoms. And for intraluminal sutures anastomosis, they could not be evaluated from the outside. But by combining both techniques, these limitations can be overcome. So this is the concept of hybrid endolap surgery. So both are complementary to each other. Now, to do hybrid endolap surgery, I think you need to have a good setup, OR setup, and also equipment. So in fact, we do have the endolap OR setup, and the first endolap OR suite established in 2005 by Professor Michael Lee in Hong Kong. Now, using this setup, Professor Michael Lee and his team were able to show a much decrease in overall workload and improve efficiencies in doing the OR. namely decrease in OR setup time, turnover time, and also the time required to set up additional endoscope. So it makes the surgery much more efficient if you want to do simultaneous laparoscopy and also endoscopy. Now, the applications of hybrid endolap OR in colorectal surgery include: one is the most common would be intra-op endoscopy during lap colorectal surgery. Two would be hybrid endolap surgery for large colonic polyps. And the later three, the hybrid endolap repair of rectal anastomotic leak, hybrid nose colectomies, and TATME are actually extension of the concept of hybrid endolap surgery. Now, the first application, I think the most common application would be intra-op endoscopy during lap colorectal surgery. And the application indications of this approach include intra-op localization of small lesions, removal of synchronous polyps. It can help to visualize endoluminal tumor margin to determine level of bowel transection. But I think the most common use of this approach is to evaluate rectal anastomosis. So the endolap OR actually allows intra-op colonoscopy to be done immediately after a lap rectal anastomosis. So the intra-op endoscopy allows three purposes. One is to visualize the anastomosis to check whether it is intact. Second is to look for bleeding, like here. If you notice bleeding from the anastomosis, you can apply clip to achieve hemostasis. And finally, we can look at the color of the bowel to see whether there's any ischemia. If yes, then we might need to take down the anastomosis. In fact, Professor Stephen Waxner's group has reported this interesting study comparing the practice of routine intra-op endoscopy versus a more selective approach after colorectal surgery. And what they found was that the routine group, they were able to pick up more intra-op abnormalities and then fixed them. And therefore, if we look at the post-operative anastomotic complications, it was much lower in the routine group when compared with the selective group. Now, of course, another more common indication or applications of the endolap surgery in colon would be the management of large colonic polyps. You know, with increasing, popularity of screening and also more advanced techniques in endoscopic technology, we're picking up more colorectal polyps during colonoscopy. And some of these lesions actually look like this, so big, big lateral spreading tumor, granular type. And many of these endoscopists who do not possess the, ESD skill will basically surrender and then subject all these patients to laparoscopic colectomy. But if we look at the literature of, doing laparoscopic colectomy for endoscopically unresectable polyps, you notice that it is, despite that it is MIS, it is associated with morbidity. And also many of these polyps are actually benign. So basically you're over-treating all these patients. And of course, now we can always do a ESD if you have the skills and technique for treating all these big polyps. But ESD is difficult to be performed, long learning curve, and also it has, complication risk like, from this systematic review, you notice there'll be a substantial risk of perforation and also bleeding, both immediate and also as a delayed complication. And therefore, of course, in Japan, they have a lot of very skillful endoscopists who can actually do ESD nicely and safely, but this is not the case in the rest of the world. In particular, many surgeons actually in this part of the world actually don't possess that, advanced endoscopic skill. So, but you want to tackle all these lesions. So that's why it's good to combine, the application of laparoscopy in doing endoscopic resection of these polyps. So that's why hybrid endolap, approach is a very good indication, is a very good approach for treating these lesions. So if we look at the literature, they also call this a combined endolaparoscopic surgery or cells in treating these polyps. Basically, there are two approaches. Either you can do a laparoscopic assisted endoscopic resection, or you can do an endoscopic assisted laparoscopic wedge resection. Now, for laparoscopic assisted endoscopic resection, it allows you for doing very good adhesolysis. You can manipulate the bowel and to place the colon actually in a configuration that facilitates endoscopic polyp resection. All right. So I'm going to show you a very short clip.
Retrieval success,
so you can see the laparoscopy. This is a tattoo of the big polyp in the ascending colon. So the after bowel mobilization, the surgeon actually make a
laparoscopic electrocautery is then used to create a defect in the
around the
layer
lesion,
and inadvertently create a.
And then basically he invaginated this area into the lumen, and
Once
then
this is
allows
performed, the
endoscopic
colon is evaginated using
polypectomy under direct
The
vision.
endoscopic.
And then afterwards, the laparoscopic surgeon can actually
A
suture
continuous
repair the
seromuscular
serosal
repair is
defect,
performed in 2 layers
thus
across the
minimizing the
previously
risk of
created
perforation.
seromuscular
All right.
defect.
So another way of doing the endolap
Colonoscopic
approach is to
assisted
do this
laparoscopic
endoscopic
wedge
assisted
resection.
wedge resection.
Therefore,
So again, this is a polyp here. So localized using the colonoscopy. And what the laparoscopic surgeon is now doing is to place 2 stage sutures, right at this area under direct vision, and then sling it up, and then you can apply a staple across this area, do a wedge resection, and then you can have a direct visualization intraluminally to check the completeness of the wedge resection. Okay, so this is how surgeons are doing endoscopic assisted wedge resection with a hybrid endolap approach. Basically, if we look at the literature, there were 18, there's a meta-analysis encompassing 18 studies on cells, and it reported successful endoscopic resections ranging from 58 to 100%, conversion to open surgery only requiring 5%, complication from 0 to 8%, and they reported a shorter operation time and length of stay when compared with laparoscopic colectomy. Of course, if you have, someone like Super Keith from Chulalongkorn, very skillful endoscopist, basically you don't need hybrid endolap surgery. But unfortunately, this is not the case. Now, and other examples of doing hybrid endolap surgeries basically are those using transcranial endoscopic platforms, which I said is an extension of the concept of hybrid endolap. Basically, for managing rectal lesions, now we have the TEM platform, TEO, or TAMIS. Basically, we're doing, these are endoscopic platforms, and we are doing laparoscopic surgery in the rectum. So basically, we are like opening up more possibilities for endolap surgery using this extended concept. It's a step of moving towards nodes. Despite, not enough time, I have to show the studies from our Mr. Chairman, William, using this approach in managing rectal anastomotic leak. He's very smart, basically, for rectal leak. Conventionally, we need to do open surgery, take down the anastomosis. But for William's group, they managed to use this approach, basically using laparoscopy to do adhesiolysis, lavage, and stoma. And then you use the endoscopic platform to do transcranial endoluminal repair. And with this approach, they were able to manage 14 patients, actually 13 with this hybrid technique and 1 after conversion successfully, and actually no patient required further intervention, and there was no anastomotic sinus or fistula noted after 1-year follow-up. So another approach of this hybrid endolap in colon would be this hybrid nose colectomy pioneered by Professor Michael Lee's group and also my very good friend, late Dr. Hester Zhang. Basically, it's doing laparoscopic colectomy without middle laparotomy wound, and the specimen will be retrieved and anastomosis achieved using the use of a TEO device. But because of time, I think I cannot show you this video, but just want to show that they have published their results in a randomized controlled trial. 70 patients randomized to the study. And what they found was that the hybrid lab group was associated with much lower pain score and also lower infection rate. And they have also analyzed the long-term outcome data. Basically, they were able to show that hybrid nose colectomy actually did not affect oncologic outcomes. Now, of course, TATME, a very popular surgery nowadays, is also a kind of hybrid nose protectomy. But of course, in the next session, rectal surgery, I think my friend, Dr. Masaki Ito, will tell you more about TATME, and I'm going to skip this slide because of time. So, Mr. Chairman, ladies and gentlemen, I would like to conclude my talk by saying that combining endoscopy with laparoscopy is beneficial in different indications to reduce invasiveness and also increase efficiency and safety of the therapy. We can see the respective contribution of both modalities to the intervention varies, ranging from simple endoscopic support for localization lesion to hybrid nose procedures. So that's why nowadays it's very important for surgeons to learn both endoscopic and laparoscopic technique. So this is really the purpose of, Professor Michael Lee and a lot of surgeons in Asia setting up this Asia Pacific endolap surgery group. We are running a lot of training courses to teach surgeons in Asia, and both endoscopic and laparoscopic technique and how to combine the two in treating colorectal disease. So in February 2021, we're going to have our 9th lower GI training course. And so please stay tuned. Okay, with that, I would like to end my talk. Thank you very much. For the last slide, I would like to let an advertisement for ESCP. because 21st and 23rd September 2020, there will be an ESCP virtual Lithuanians meeting. And so I think they put up a very good program, with, different topics on coloproctology. So I would encourage you to join this ESCP meeting. It's also free of charge. So really, I can stop now. So thank you very much for attention.
Well, thank you very much, Professor Young. And it is a very nice talk. And we leave all the questions to the end. I think, Jungi, you will have time for you to express your thoughts on your surgery. So don't worry, because our next speaker, Dr. Uehara, is not online. So we'll jump to the next speaker, which is Mina Shane. She will be talking on the strategy of laparoscopic surgery for splenic flexure colon cancer. Mina is a graduate of Yangming University School of Medicine, and she's currently the chief of colorectal surgery here in my hospital, China Medical University Hospital, Hsinchu branch. And she has currently she just graduated from, she just received her disease on the degree on the PhD. So without further introduction, and she's pretty famous nowadays in Asia, so we'll have Mina online now. Please, Mina.
Thank you for your kind introduction. I will share my screen.
You close your.
Is it okay?
No, you close your.
Oh, I'm sorry. Yes.
Please share your screen, please.
Okay. Is it okay?
Yeah.
Good morning, everyone. It's my great pleasure to be invited and share our experience of splenic fetal colon cancer. At first, I have to say I miss you guys very much, and hopefully we can see each other face to face soon. And thank you for the invitation from Professor William Chen. And some surgeons said splenic fetal colon cancer is just some man's land. It means only the expertized surgeon can explore this area very well because it is a complicated area. We have to divide several ligaments and prevent from injury to the pancreas and spleen. And as I know, some surgeons did not routinely make splenic flexure mobilization because of higher risk of complication. And because of the relatively lower incidence of splenic fetal colon cancer, usually less than 10% in all colorectal cancer. So there are doubts about the definition, and some surgeons are still curious about the extension of bowel resection. Or should we do it laparotomy or laparoscopically? And as laparoscopic CME is feasible or technically successful in treatment of splenic fetal colon cancer. So we will talk about these topics. The definition of splenic fetal colon cancer is the tumor within the distal third of transverse colon and proximal third of descending colon. By the AJCC tumor staging system, the definition of splenic fetal colon cancer is the tumor just past inferior to the spleen or anterior to the tail of the pancreas. And this area is defined as splenic fetal colon cancer. How much extent of colon should we remove for splenic fetal colon cancer? Should we do it as subtotal colectomy, extend left colectomy, or should we just do the left colectomy? We try to find out the answer by evaluation of the lymphatic drainage. Basically, the lymphatic drainage can go to two different sites, to the middle colic artery site along the superior mesenteric artery route, or to the left colic artery along the inferior mesenteric artery route. But mainly the lymph node locates in epiploic or paracolic region. Dr. Watanabe tried to figure out how the lymphatic drainage go by laparoscopic injection of ICG, indocyanide green, to trace and record the lymphatic drainage. He injected the ICG just in the beginning of the operation, and the injection site is into subserosa and submucosa layer around the tumor at 2 points, and it measure and record the lymphatic flow at 30 minutes after injection. And the result is, it is common in almost 40% of patients have left accessory aberrant colic artery. And he found none of the patients have lymphatic flow to both left colic artery or left branch of middle colic artery. So the lymphatic drain goes either to one side or to another side. The lymphatic drain doesn't go to both sides. And if the tumor located at distal third of transverse colon, the lymph flow run, all of the lymph flow run to left branch of middle colic. None of them go to the left colic artery. But if the tumor located at proximal third of distal colon, the lymph flow ran, all of the lymph flow ran to the left colic artery. But there is an interesting finding that the lymph flow ran to the root of IMV in about 60% of the patient. However, if the tumor is just over splenic fetal colon, the lymph flow varies, and it can go to the left branch of middle colic or to the left colic artery, but it doesn't exist in these two areas at the same time. So how much bowel should we remove? It is found that the oncological outcome compared to left colectomy only, or extended right colectomy only, or total colectomy, these three different methods has the similar oncological outcomes. So each of the methods is suitable for splenic fetal colon cancer, but Professor Mashius, he found if the tumor combined with synchronous liver metastasis. They perform subtotal colectomy for this kind of patient with liver metastasis. They have chance of lymph node metastasis to right colic artery. So in this kind of patients, subtotal colectomy is suggested if the patient synchronously has liver metastasis. And external right hemicolectomy, comparing to left colectomy only, has the advantages and the disadvantages. The advantages of extended right colectomy is tension-free anastomosis and fewer risk of jejunal compression or internal herniation, and it is easily to have colonoscopic follow-up. But the disadvantage of extended right colectomy is there is excessive bowel resection, and for elder patient, there is high risk of diarrhea or incontinence. So how do we choose extended right or left colectomy? It depends on patient's condition. But basically, if the tumor located in distal third of transverse colon, we should divide left middle colic artery and IMV at the root. But if the tumor located in proximal third of descending colon, we should divide the vessel of left colic artery and the IMV. But if the tumor just over the splenic fracture, we have to divide both the left branch of middle colic and left colic artery and the IMV. And the extent of bowel removed is independently and decided by the surgeon. We all know laparoscopic operation is feasible and have the same oncological outcome comparing to laparotomy, and the result in several randomized control trials shows it is feasible. But in this trial, including classic color coast of Barcelona, all of this trial exclude splenic colon cancer, probably because the technique is more difficult, and partially because of the low incidence. So from this randomized trial, we cannot get the conclusion that for a splenic colon cancer, laparoscopic operation is the same oncological outcome. But there are more and more studies show the comparable outcome, either from Italy or from Korea. If the operation is done with CME and CVL, there will be comparable short-term and long-term outcome.
You have to speed up.
Okay. So the surgery technique include complete mesocolic excision, central vascular ligation, and we prefer medial approach. And this technique should involve full mobilization and tension-free anastomosis. The IMV ligation is important because almost more than 60% of lymph flow goes through the IMV, and there are existence of accessory middle colic vein. In the beginning, we do the splenic mobilization at first, and this is the medial to lateral approach. The gauze help us to prevent from iatrogenic small bowel injury by electrocautery. And we enter the laser sac by division of the peritoneum just along the surface of pancreas. And this technique is also feasible in lower rectal cancer to mobilize splenic fracture. And then we do the CMV by complete remove the mesocolon and mobilization from the toes fascia. And the dissection should go to the most lateral side. And we can also divide the omentum. And we usually divide left coronary artery only and preserve the sigmoid artery to prevent from excessive resection of sigmoid colon. And about half of the patient has left coronary artery directly branch from AMA. And during the left coronary artery dissection, we should remove all the lymph nodes at the AM root. And then during the dissection, bleeding may happen. And if we cannot control the bleeding well, sometimes we have to convert the operation to laparotomy. A gas is usually useful during the laparoscope for protect other organ or to control bleeding.
You know, you have to speed up. You're a bit behind.
Okay, so I just want to show the disaster of bleeding, but with the assistance of the suction, we can clearly see the bleeding site and fortunately control the bleeder by clip. So we just move to the final part, the anastomosis. If the bowel length is sufficient, we prefer extracorporeal end-to-end anastomosis, or sometimes we can do intracorporeal isoperistatic anastomosis. But if the bowel length is insufficient, there are another two options. The extracorporeal end-to-end anastomosis has the least insult of bowel length, and it usually needs a small laparotomy wound for reconstruction. And we suggest to have closure of mesenteric defect to prevent from the risk of internal herniation. And comparing to anti-peristatic, we prefer isoperistatic because it requires fewer lengths of bowel. And the advantages of intracorporeal anastomosis is fewer risk of vascular injury, fewer risk of mesenteric twist, and less wound pain.
Can you skip the video?
Yes. And the other option is retroileal transmesenteric anastomosis.
Skip that, yeah.
Yes. And welcome to join us in November 21st for the International Colorectal Surgery Forum held by Professor William Chen. Thank you.
Well, thank you very much, Mina. And it's an excellent talk, but we did not give you enough time for you to elaborate on what you wanted to talk on. But I'm very sorry for have to stop you from your talk, and because our final speaker, Dr. Uehara, has joined us from Nagoya now, he thought, and it is our pleasure to have Dr. Uehara with us today, and he's gonna talk on laparoscopic right side colectomy. I think it is interesting today that we have left side and right side, and we talk about CML, we talk about CVL and CME, and we'll have a interesting discussion after Dr. Uela's talk. And Dr. Uela is a graduate from is currently an assistant professor from in the, oh, I'm sorry, they did not give me the right one. He currently is the chief of colorectal surgery in Nagoya University. And I think Dr. Uela is very famous in colorectal surgery, especially in the pelvic exonerization or treatment of the recurrent rectal disease. And because of time factor, I like to hand this microphone to Dr. Uehara, and welcome to join us, Dr. Uehara. You're on now.
Yeah. So can you hear me?
Yeah.
Oh, can you see my presentation? No?
Please share.
Can you see my slide?
Yes.
Okay. So this is Kei Uehara from Nagoya, Japan. So thank you for inviting me. So William, oh, it's my great honor so to talk in ELSA virtual meeting. So my talk is so laparoscopic surgery for right side colon cancer. So in Japan, the COVID-19 situation is getting better. So, but we cannot be our guard. So I started my presentation. So right hemicolectomy is an essential surgical technique for colorectal surgery. So the foundation is a complete mesocolic excision and central vascular ligation. So this slide shows Japanese classical right extended hemicolectomy for transverse colon cancer. So we call this a discrete dissection. So first, I show our concept and technique of complete mesocolic excision. So this is my favorite tool. So mainly I use monopolar electrocautery. So we have a various approach for mobilization of the right side column. So lateral to medial is an easy way to understand, especially for beginners. So because this is the same way as a conventional open approach. So but far to near is not good way in laparoscopic surgery. So near to far is the best way in laparoscopic surgery. So medial to lateral is the commonest way. So I show the video. So assistant forceps, so grasp the idiosyncratic pedicle, and we can recognize where we can should cut. So here, we start here. So but metastatic lymph nodes are sometimes present around the idiosyncratic pedicle. Oh. So I don't like this approach. So assistant forceps might flash lymph nodes along the ileochoric vessel. So could you allow this situation even in the advanced idiosyncratic cancer? And it's sometimes difficult to enter the appropriate layer, especially in obese patients. So my favorite approach is the inferior approach. This approach needs initial peritoneal dissection between the mesoileum and the retroperitoneum, and near to far mobilization to the hepatic fracture is possible. So key of this approach is how to keep the surgical view, so especially removal of the small bone. So this slide shows the position and the post site for right side correction. The operator stands on the left side of the patient and the scopist is between the legs. The assistant stands on the opposite side. The operator uses these two ports, and this is a camera port. So during the mobilization of the right column, the position is the head down and the right side down. So after that, the position changes to head up during the lymph node dissection. I show the video of the mobilization of the right column. The membrane is covered the lateral peritoneum. Oh. The small bowel was moved to the right upper abdomen. The peritoneal dissection between the mesoileum and the retroperitoneum was done. Dissection was extended to the duodenum. The assistant forceps make a screen of the mesocolon. And my own left hand pulled down the retroperitoneal tissue. The mesocolic screen should be remade suitable. So first we put down the retroperitoneum and the mobilization is static around the duodenum. So when we keep the appropriate layer, the ureter and the gonadal vessels are covered by the membranes and never exposed. To keep this appropriate layer, so putting down the retroperitoneal tissue by the left hand is essential. So you can see the ureter and the gonadal vessel is running here. So to keep this layer is essential. So we have to keep and extend this layer. So my left hand is pulled down the lateral peritoneal tissue. So dissection is going up to the hepatic fracture. So here's the lateral edge of the duodenum. And this is the accessory right colic vein. And this is a transverse colon. It is the pancreas head. So this is transverse colon, and mobilization is going up. And finally, we can reach the hepatic fracture. So again, the retroperitoneal space is covered by the same membranes. So this is accessory right colic vein. So keep the layer is most important. So in colorectal surgery, so it's resulting in the less bleeding. So I prefer the monopolar electronic coating. So this is I think this is the most easy tool there. So to keep the layer. And this is the hepatic fracture. After that, we change the approach. The assistant. Oh, this is a idiosyncrasy. Okay, and after that, it is the pancreas, and we detach the omentum from the transverse column. The assistant lift up the omentum and left hand pull down the transverse column. The dissection is done between them. Okay, this is after mobilization. So next, central vascularization. So this schema shows most of the lymphatic flow. So yellow is the lymphatic flow. So are running along the, not the SMA, so but here, SMV, surgical trunk. So our concept of this lymph node dissection is to remove the enough fat tissues along the SMV. So, but this never been means we had better to expose the left edge of the SMV. So I think we should expose the right edge of the SMA to remove the so enough lymphatic flow. Okay. This is so dissection area. So after lymph node dissection, so so to expose the right edge of the SMA, so this is a ideal. It's an ideal approach. So however, we cannot know. So this line, so as first sight, so especially in the obese patients. So we should cut the peritoneum so far away place. So of course we should preserve the nerve plexus of the SMA. So yeah, this is maybe so. In fact, we should do. This is difficult. That's ideal, but difficult. So I show the video of the lymph node dissection. So usual, so we preserve the so main trunk of the so middle colic artery and only remove the right branch. So after mobilization of the right side column, so the assistant forceps grasp the mesoileum, not the pedicle of the ileal thick vessels. So under the ileocolic vessels, we can make the window. So first we expose the SMV at the peripheral of the ICV. So SMV is fully exposed, so going to the center. So you can see the ICA is running the ventral of the SMV. So here is the root of the ICV. I click it and divide it. And click. So recently we use a sealing device. So ICA is also clipped and divided. So we expose so right edge of the SMA. So at the surface, you can see the nerve plexus of the SMA. We have to preserve the nerve. The section is further going up along the SMV and the SMA. You can see the right colic artery is arising. And at the upstream, you can confirm the middle cortical artery. RCA is clipped and divided at the root. So this is the middle cortical artery. It's a left branch and right branch. So we expose so right branch of the middle cortical artery, but be careful. It's the middle cortical vein is running so just behind the middle cortical artery. We divided clip the middle right branch, the middle cortical artery, and we have to expose the assembly surface. And this is the middle cortical vein. A very small branch is here. And we divided this. And vein is so divided at the root. And this is so surgical trunk, and the gastrocolic trunk is here. And this is the pancreas surface, and this is the accessory, so right colic vein is also divided. This is after lymph node dissection. So this is only divided right branch of the MCA. So the lymph node dissection around the root of the MCA is insufficient. But so for patient without swollen lymph nodes along the MCA, so even in the proximal transverse colon cancer, so we can do this lymph node dissection. So I think this is only D2 sulfur that are not this way. So, but for patients with swollen lymph node along the MCA, so I divided the root of the MCA with D3 lymph node dissection. So for safe and precise surgery, so in colon cancer surgery, to keep the appropriate layer is the most important, so resulting less bleeding. So I always say, so reddish operative field brings a loss of quality. So it's a simply a bad habit. So thank you for your attention.
Thank you very much, Professor Uehara. Now,
thank you very much.
We still have some time, about 5 to 10 minutes, about 10 minutes, several minutes. And okay, we have a question for you, Professor Uehara.
Yeah.
The question is, how do you use the monopolar?
Oh, so I think monopolar is the best way to keep the layer.
Yeah.
So and the
what is the setting of monopolar?
Oh, setting it's I use only coagulation.
Only coagulation.
Yeah. Not 30 the blend and not spray mode. I don't like spray mode.
You don't like to spray them.
Yeah. But so I think I use so near the bowel, the power is down to the 15 to 20. But the usual 30.
Thank you very much. And is there any question from our speakers that would like to ask anybody, any of our speakers? You have any questions, Simon?
Maybe a question for the whole panel. For splenic fleshy tube actually is not very common, so it's indicated in Minya's talk. So I just want to ask the panel, when you encounter spline pressure tumor, do you routinely do ICG for that?
Okay, we started from Professor Kim.
Hi.
Do you really do ICG? Do we use ICG doing
No,
your
no, no, I have not.
How about Professor Naito?
Yeah, I use the ICG only for blood supply tests. I mean, in case of the TST. Otherwise, we don't.
So you don't use it for lymph node detection?
No, it's not approved for, by the National Insurance.
So
That's the reason why.
for insurance. So about Mina, do you use that routinely? Mute, you need a mute.
Mute.
Yes.
Unmute.
For splenic facial colon cancer, no. But for rectal cancer, if I would perform lateral lymph node dissection, the pelvic lateral lymph node dissection, I would do the ICG and inject ICG just in the beginning of the operation, and it's transanally distal to the tumor.
How about Professor Uehara?
Oh, same. So Professor Naito. So I use only to confirm the blood flow, but not use so to check the lymph node flow.
Okay. I also like to ask the panel, how many of you use colonoscopy doing your laparoscopic surgery? Can you raise your hand? Okay, only 3 of us, 3 versus 3. Okay, we routinely use colonoscopy, even though in a right colon or left colon. So we routinely scope it. Like Simon have said, it's really easy, and also there's a question from the panel to the panel on your thoughts on do you do a preoperative treatment for a pre-op T4 colon cancer? What would you do for other panel?
For the colon cancer, you mean?
Yes.
For colon, right? Yes.
I don't do any pre-op therapy for the colon cancer right now.
Yeah. Would you do a laparoscopic surgery for T4 cancer?
Yeah.
Of course, do laparoscope. How about Uehara, Professor? You do?
Oh, it's a case by case, but mainly it's difficult to do a laparoscopic surgery for people colon cancer with so bladder invasion, so ureter invasion. But so the other invasion is, I think, it's acceptable.
Can I ask to Dr. Chen?
Yeah, Dr. Sheikh.
Okay, Mina?
Yeah.
Yeah, so I think for complete mesocolic excision for splenic facial colon cancer, I think most difficult point is left accessory aberrant colic artery.
Yes.
So you do try to find out that and the ligate in the just at best that vessel's origin for complete mesocolic excision?
Yes, we will try, because when we perform the left branch of middle colic, we usually along the inferior border of pancreas. And if we encounter this vessel, we will divide it.
Without any hesitation or, you know, your palpitation, you can do?
You mean the
any difficulty?
accessory of right colic artery?
Accessory of right colic artery?
You were afraid of it without hesitation.
Yeah. How about Professor Dr. Chen? You are a teacher of Dr. Chen?
Yeah.
How about you?
Not afraid of it, yeah. Of course not. Okay, one more question from the audience. We'll probably have to wrap it out after this question for other panels. Do you consider, when you explore SMA, doing CME and CBL, do you think that you might damage the nerves or causes the diarrhea after surgery? Starting from you, Dr. Naito.
Yeah, I think so. So we have to care about not to, injure the plexus, nerve plexus around the SMA. So I'm go outer layer of the plexus, nerve plexus, when we do the dissection around the SMA, in case of the transverse colon cancer or something.
How about you, Dr. Wela? Do you think will damage the nerve or causes diarrhea?
Yeah, I agree. So I preserve the number teeth. Yeah, and only remove the fat tissue, so outside of the nerve so fiber.
We have 3 minutes left. I want to ask Professor Kim that. What's the difference between CBL, CME, and D3 dissection? Do you think there's any difference?
I wanted to ask to Dr. Uehara that same question. Could you explain what is the difference between the CME with the CBL and the D3 dissection of Japanese surgery?
Can you explain?
What's the difference between CME
with the CBL and the D3 dissection of Japan?
I think so. Main difference is so length of the removed so colon. The other, I think the almost same. With so length is maybe very different.
Well, Professor,
I can say it's exactly the same. A CME with the CBL is not proper noun. It's a common noun. So just Japanese D3 dissection is a little bit shorter longitudinal margin. Central radicality, absolutely same as Dr. Hohenberg's CBL. So I think it's the same.
Well, Professor Naito, do you agree with that?
Yeah, I think it's a different of the concept to dissect the lymph node and the CML and CME and the D3 dissection. That technique is almost same, I think, and also result is also almost same, I would say.
It's very important. Result is almost the same.
Yes.
Yeah, it's clinically same.
Simon, you want to comment on this?
I think CME, I think the Professor Hohenberger's concept CME plus CVL. CME is talking about the embryological plane of dissection, whereas CVL is talking about the vessel, the lymph node dissection. I agree with Dr. Naito that technically the lymph node part actually is the same for CVL and D3, but for Japan, I think they have a specific definition of what constitutes a D3 group, what constitutes a D2 or D1, and then that's not mentioned in the original Professor Hohenberger's description. So technically, I think it's the same thing, but it just concept will be slightly different.
Okay, time's up. We have to move on, and so we'll move everybody back to the waiting room. And thank you very, very much. And I think it's very nice. And I'll see you guys soon. Thank you.
Thank you very much.
Thank you. Thank you very much.
Thank you.